Okay, safety advocacy. That's a big part of what we do. We taught you the 60-second safety check when you walk into a room, making sure that there is no hazards on the floor. Remember, if we see something on the floor, and nowadays, honestly, the number one thing I pick up off the floor are gloves that have fallen as you pull your glove out of the box on the wall. Those gloves that are falling on the floor, those need to be picked up. You put your foot on one of those things and you could affect your balance, okay? So we need to be picking up anything that's loose on the floor. The National Patient Safety Goals was developed by the Joint Commission, and they update these yearly. I have actually, let me go ahead and just put that up right now instead. The National Patient Safety Goals are updated each year for which ones they feel are the most significant. And there's several that, and they typically, the report itself is thick. It's, it'll be 30, 40 pages, and it explains in detail all of these. But the ones that we were really, already about IDing patients and communication. One of the ones that we had on our list that we're looking at is about medication safely and about medication reconciliation. You do recall when we did the Janice Jordan video, those of you who've done that, she was the lady who was in the ATI real life video. Do you remember one of the things that happened was the nurse had to call the pharmacist in an attempt to try to get a list of the patient's home meds because she didn't come in with one. She was in no shape to give a verbal history of one. And so he was calling because she'd been hospitalized before, figured that they would be records of what they'd had before. Probably another good source to do I'm ahead of myself. What is medication reconciliation? Could anybody give a brief definition of medication reconciliation? What we're doing when we're in a hospital and somebody's admitted and we're doing a medication reconciliation? Yes, Raymond.
Medication reconciliation is just when we go over their prescribed meds for like at home and make sure that we have orders for those to continue those prescribed medications during their stay in the hospital.
Okay, that's the kind of the overarching thing. We're getting the list of their meds and we're entering it, and you'll need to ask your nurses to show you where they put that now in the electronic health records. And then what it does is when they're admitted, the provider then can go in and click, continue, hold, continue, whichever ones they want to keep going over home meds to continue them. And then those get moved automatically into their EHRs now. Some places you go, there'll still be a paper form, and the provider then has to go through their Markham and sign it, and for them to become orders. But we're wanting to see what has the patient been on, and we want to make sure that we don't inadvertently leave something out that they need when they're admitted, because the patient may or may not have an up-to-date record on them. Encourage all your patients to keep a written record of them in their wallet, and so that they would always be able to bring those. Some providers will just tell them just put all your medications in a bag, but the problem with that is there may be medicines they were taking, then they got a new prescription. Well, they just push the other ones to the back. And so if they bring them all in, it could be very confusing. But I want that list of what they were taking at home. The provider needs to indicate what to continue, what not to. And then the next step, and this is the one that is probably to me even the more important, is that when they're ready to discharge them, they're giving orders, giving them new prescriptions. Then I need to pull up that list again of the home meds and have that provider compare it. Say, okay, she was on 20 of furosemide. Now it was BID, and now you're sending her home on 40 once a day. What do I tell her? I tell her not to take those, and I make sure that she understands that she doesn't take the 20 and the 40. Is it okay if she understands to take 2 of her 20s? How do we do this? And so that we're lining back up what's going to go home. Make sure that the patient understands I'm taking this instead of this, or he's adding this with this. or he's cutting me back to half a dose of this, and making sure that they understand how that goes, because if I don't, I run the risk of the patient overdosing on a medication. If she's taking 20 of Lasix BID and then she comes home and starts taking 40 on top of it, she's going to be dehydrated in just like that, because I mean that's double the dose that they've been receiving. So that you want to make sure that the understanding is what I take, what I don't, when they go home. So medication reconciliation happens anytime at any entry, any point of care to healthcare. And then if I've been in an acute care setting, been hospitalized or rehab, I need to have a medication reconciliation happen again when the patient is discharged home. And so that's why your discharge is really important, more than just reading to them a list of the medicines that they're on. It's also looking at, remember now you have this med at home, but that's a lower dose than he's giving you now. And make sure she understands, don't take both. So it becomes real important on medication reconciliation. And that's why it's listed as a national patient safety goal, because the patient may see 2-3 doctors easily that all give them different medications, and that information should be shared by providers, but doesn't always happen. So make sure you have a list every time you go to your doctor, show it to them, they update it, so your cardiologist has the same list as your family practice doctor, and they have the same list as, say, your gastroenterologist doctor, to know that I'm taking medications that can affect other systems. So it's really important that everybody's on the same page by them having medication reconciliation happen. And you're going to do a lot about the infections. You'll see that with your infectious and immune lectures. The last one I want to point out is really important, preventing mistakes in surgery. There's a universal protocol. It's about the correct surgery, so the correct procedure, done on the correct person at the correct place on the patient's body. There are all kinds of horror stories out there about somebody who had the wrong foot taken off, or the wrong organ removed, or whatever. So it's really important that we make sure it's the correct surgery, correct patient, and the correct place on the patient's body. If necessary, like if it's like you've got 2 of them, like 2 arms or 2 legs or 2 eyes or 2 ears, they would mark the correct place on the patient's body. And typically they'll have the patient and doctor sign on their skin with an indelible marker that won't wash off when they do their surgical preps, so that it is verifiable that you and the patient have agreed this is what we're going to do the surgery on. And then in addition, when they go to the surgery, they pause. There's always, when they bring them in, they've gotten them set up. Sometimes the patient's still awake and they do it. Sometimes it's after the patient has been given medication, but they stop, and you have either the circulating nurse and the doctor or tech, somebody else in the room. They called a timeout. They stop and they again verify correct procedure, correct patient, correct place, and that's called a timeout. And that needs to be done so that we don't make a mistake. If they're doing multiple procedures, that should be done when they move to the next procedure. Again, they should repeat the whole process over again. So really big on the national patient safety goals. We're looking at the surgical issues, and then the medication reconciliation again, because we're looking at chronic illnesses and people who have polypharmacy. It's not unusual for a patient to have half a dozen different medications. And we know that when you hit 4 medications or more, it's a high probability that they're going to have a reaction because of the number of medications they're taking. And we need to be monitoring those sort of issues for problems with medication drug interactions. Okay. All right. Let me go now back to my slideshow. So that was the national patient safety goals, and wanted to remind you, now you had restraints in foundations, but I did want to remind you, I'm trying to figure out what I've done to make my screen. Let me see if I can downsize the screen just a bit over here so that it all fits. Oh, okay, that's much better. All right. Remember about restraints. We use the least restrictive means possible. Use whatever is least confining for the patient as possible, and discontinue it at the earliest possible time. All right. Now, why do we do it? Either to protect the patient's safety or the staff's safety. And that's the reasons we would do that. It doesn't have to be violent behavior. It could be behavior where, like, if they become confused and they're pulling out their NG tube, but they got tube feedings. I mean, they could pull that and fling formula all down through their airway and everything. So sometimes it's just because of agitated behavior and the patient just not able to consciously, keep themselves to tolerate a procedure or deal with, something that, like an IV. You'll see them where they'll pull their IVs out or they'll pull their NG tubes out. Oxygen's always coming off. It just seems like it's on and off, on and off, on and off. But when it's something that could cause harm, like the patient pulling out the NG tube or a trach or a PEG tube, something like that, then we really have to be concerned. What are we seeing more of, though, for this? What's the least restrictive means you're seeing a lot of on these hospital units now? Somebody who's been on maybe a rehab unit, what are you seeing now for least restrictive means of, go ahead.
Bed alarm?
Bed alarms. So we got bed alarms, and that's a way just to let us know that they're before they actually get up, and I can just go back in there. What else are you seeing with that? What else are you seeing in terms of ways of protecting a patient, keeping them safe while not having to tie them down?
Side rails?
Well, the bed rails, yeah, maybe using the bed rails. Has anybody seen the use of sitters? They're now paying staff to sit right outside the patient's room so the patient can have a degree of privacy, but they're there immediately in case that patient tries to get out of bed or pulls at something. And so this is a good thing because they're realizing that the person may be less agitated if I don't restrain them physically, but I have somebody who's immediately available to redirect them or to help them so that they don't cause harm to themselves, okay? So the least restrictive means possible, and seclusion for, especially if it's somebody who's become agitated. Sometimes people who get hospitalized, if you are an alcoholic and you get hospitalized more than a couple of days, or you're used to using heroin, maybe they haven't identified that information. Maybe they haven't given you that information, but they start becoming restless. It may be, they're becoming confused and difficulty. It may be that they just need a quiet room because all the stimulation, especially if you're coming off of heroin can, oh my gosh, it's just like pianos on the chalkboard, and it can really make them just so agitated. It may be they need a quiet environment where I can check on them frequently. Again, a sitter may be indicated in that situation. Seclusion for somebody who escalates when they're stressed or anxious. And then remember, documented assessment within an hour of putting on the restraints, and we need a physician's order, and that needs to be renewed every 24 hours. Now, mostly we're talking about physical restraints. When you do your complex clinical rotation, you're going to see a lot more use of chemical restraints. And that has its own set of issues, but sometimes we're using chemical restraints now. Well, what are chemical restraints? Medications like benzodiazepines, they can come in a gel or a cream. You put on gloves, you put the ointment on you, and then you're just rubbing their arms and putting the medication on them and calms them down. So they may be using chemical restraints now. Care with those, because you need to always be able to assess your patient's baseline level of confusion or competence, okay? How alert can they respond so that I don't miss deterioration in status just because they've been sedated. So keep that in mind, that as the physical restraints, we don't see those in physical restraints as much as, I mean, almost, I very seldom see those now. But I am seeing more use of chemical restraints. So that's another area where, again, the least amount necessary. You need to be able to reassess that patient so you don't just keep them knocked out. You let that medication lapse, wear off, assess, are they now more alert and oriented and able to control themselves, or do they need a reapplication or another dose of the medicine? Okay, but I really need to be able to assess my patient to make sure there's no deterioration in status in between doses. All right, CUSIN. The National Patient Safety Goals is one big thing that we have to concern ourselves, but CUSIN was from the Robert Wood Johnson Foundation, and this started many years ago. And what they came up with was a list of competencies. This is for quality, safety, and education in nursing. And it was indicating that one of the things that would provide better outcomes for patients if nurses were trained to think in terms of what keeps patients safe. And this isn't this isn't thinking like, oh, bed rails and give them their call and all that. This is more it's more take a step back and looking at the big picture. So CUSIN has these 6 competencies: patient-centered care, and that sounds like, well, duh, but thinking from the patient's perspective, how's he viewing all these people? You know, how are they interpreting all of the stimuli that's coming in from them in a strange environment? Teamwork and collaboration. If I'm making sure that we're together, you know, the different therapies and the providers and the nurses are all kind of making decisions together. And many places where the patients are very ill, or in rehab, they will have basically team meetings where they will discuss the patient's care, and you hear from the different team members' perspective. Physical therapy said, well, this is where they are, and nursing saying, yeah, but I'm dealing with this, and how can I get this to happen when you're doing this? And so they can work out what's best for the patient by shared decision making. Teamwork, collaboration, the second competency. Evidence-based practice, you had that when you had your lecture on nursing process, but I'll just remind you again, evidence-based practice is like a 3-legged stool. I've got the evidence from the research. I've got what is the provider's expertise, or can be the nurse's expertise as well, and what is the patient's desire in all of this. So that evidence-based practice is where those 3 components overlap. That's evidence-based practice, and typically that is what is best practice, where the patient's needs and desires, the clinician's expertise, and the research come together to provide a better outcome for the patient. Example of that would be something like, some of the health promotion issues, like mammograms and for breast cancer screening, and when they start those, depending on your family history, at age 50, but say your family history, you've had a couple of like an aunt or a grandma who had breast cancer at a young age, or even at an older age, but you've got multiple people in your family, and you talk to your provider and say, I'm really concerned that I should have go start having my mammograms at 40 or 45, depending on the age in the family that it first occurred. And your provider knows what the research says, that, less than this age, you're not as likely to have it. But I'm also hearing the patient's history and her family history, and my expertise knowing that it can show up frequently in people who have a family history of it. Therefore, I would go ahead and order that if I was a nurse practitioner or a family physician. That's using evidence-based practice, where I've got that 3 things coming together to provide a better outcome for my patient. Quality improvement. Most of you are in hospitals of Providence. Those of you who are at Las Palmas, they have these boards, but I forget the name of them. They're called Gimbal Boards, but basically they have a board in every unit, and it tells you what they're tracking. They're tracking how many people had catheter-associated UTI. They're tracking how many patient falls they had. They're tracking how long it takes from the patient walking into the ER before they're discharged or before the doctor sees them. And they're wanting, and that data that they're collecting shows a trend that's not consistent with the standard of care. For instance, our level of catheter-associated UTIs is higher than the hospital average for this unit. Well, what's going on? And so then they take that quality improvement is doing this research and improving my outcomes by implementing new or better or improved strategies, or reinforcing that this is our strategy and it works, but you've not been doing it. For instance, like with the catheter-associated UTIs, the standard is there that I'm supposed to ask every 24 hours if this patient needs this Foley, but we've just not done it. We just really not approached the provider about it. Well, they're going, the policy, there's nothing wrong with the policy. We're going to re-educate and do a staff in-service on what is the policy, how to do it, and they may implement what they call a nurse champion, they call them, where that's an assignment for one of the nurses on duty, is to go each room and see what the date is and approach the nurse and say, hey, just reminding you, this patient's had this Foley now for 5 days. Where are we with that? And is there a good medical reason for this to continue? So that's how they can use quality improvement. They look at their outcomes. If they see that they're not where they want them to be, they after they've collected the data and evaluated the process, do I need to change my process, or do we need people to follow the policy? Maybe that's the problem. Quality improvement. You'll also start to hear the phrase, this change, when I was, probably about 15 years ago, they were calling it quality assurance. Then it was quality improvement. Now you're beginning to hear performance improvement. And again, these are all what they call rapid cycle. We're taking, we're doing short amounts of time, and often these will be like for 3 months that they're studying the data, and they look at the situation, and then they implement their changes. They study it again, see did the changes work, or the outcomes improving. Quality improvement, performance improvement. You'll hear that word being used now interchangeably. We've talked about for safety, the National Patient Safety Goal. So all of this stuff that's on here, you're supposed to be taught about it in your nursing school. So consider yourself taught. Okay, you'll get it again. You had it before, you'll get it again. But we do continue to layer this information because of the importance of the safety and training in nursing education. Informatics, don't forget, the reason we're supposed to be having all this informatics and stuff, this technology is supposed to improve patient safety, but we need to make sure that we're using things correctly, like the SCDs. Yeah, we've got those out there. We've got computerized charting, and that's great, but we need to still be, making the effort to do our part in those, paying attention to the trends. You've got the graphic record now, and it's beautiful. It's all across there, and it'll put the labs with it, and it's just gorgeous. But if you never look at those results in that electronic health record, it's not doing your patient any good. It's not keeping your patient safe. So those are the six areas of quality of QSIN, quality and safety education for nurses. And again, there's a lot of information about risk factors for falls. The videos I showed you this one. This is also a good one about the home. I think most of you know that information. There were two people did the thing on fall risk, did a really good job on that on the discussion board. You might go there because they just list out, bink, 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 all of this information. So it's all there, just kind of in 2 clicks, and you've read most of the good stuff for fall risk assessment and fall risk assessment in the home. I think it was, I can't remember if it was Megan or Letty who put the one up about the TUG, the timed up and go test. And I haven't seen it used a lot in the acute care setting, but I have seen it used in outpatient settings where they put a marker out there 10 feet away from a chair. Your patient's seated in the chair without using their arms to push up. They're supposed to stand up, walk down to that, around that marker, and come back and sit down again. and they need to be able to do that in less than 14 seconds, okay? And so if they can do that, then they're less risk for falls. If they cannot do that, there's actually an increased risk for falls because they're having to slow down to navigate turns and transfers and getting up and out of a chair, all right? So the timed up and go, and it's called the tug test. But those are all good things, good tools you have at your disposal. There's all kinds. There's the Heinrich, there is the Morse virus that we're typically using, although I think it's really limited. It's really kind of designed just for the acute care setting, and it's not really looking at the patient's living situation in terms of what's going on with them or the physical assessment of the patient that indicates the risk factors like we saw in the video. Sorry, I'm trying to, my little thing just there we go. All right, then the next section, and this one is a little less intuitive. We have a section on bioterrorism every course, and the reason we look at it is because of the concern that as terrorism becomes more and more prominent throughout the world, we can expect increasing use of bioterrorism, because if they can find a pathogen that's easily transmitted, high mortality, causes panic, and requires special surveillance, then it would be the ideal bioterrorism. And regardless of where your opinion is on whether or not the coronavirus was accidentally or intentionally released, look at how it would easily fit this sort of category if somebody could figure out a way to control that. Easily transmitted, high mortality, causes public panic, and causes special enhanced disease surveillance. I mean, we had to invent a test for it, you know, so that those are the kinds of things we look at. Back in 2001, just after September 11, when the Twin Towers were, you know, basically exploded, people started receiving anthrax, the spores, which was it's kind of like a powder in mail. And when they would open the mail, and if they inhaled that, the powder thing, those people who inhaled that, half of them died. And because it was anthrax spores. And so they were sent to like judges, political figures, people, you know, that were public figures like that, that maybe were involved in certain decision levels or decision making of some controversial cases. And so it caused an awareness of anthrax. And so that's why it's still in our content. I would like to see this updated to some of the more recent ones, but that's what we're studying. So we're going to learn anthrax, and then we're going to take a trip down memory lane also and learn about smallpox. But first, anthrax. So anthrax is a bacillus, and it causes especially cutaneous lesions. Cutaneous lesions is like, okay, that's not a good thing, but you know, cutaneous lesions that's like doesn't look real bad. So if it gets on your skin, it creates nasty sores like this that looks like a crater with this dark eschar in the middle of it. And this came from contamination from livestock is where we originally saw this, until we started having the bioterrorism where people were mailing the spores. And the problem with the anthrax is that it produces spores. Spores are, spores are the byproducts that are produced by some bacteria, and the spores, unlike the bacteria itself, they have a really tough shell, really hard to kill, and it takes a lot of effort to do so. So the Bacillus anthracis, it produces spores. These spores release toxins, and those toxins are what injure our body. Now, it's not known to spread person to person, so it's not considered contagious. But it is contact precautions because it can be contracted skin to skin, okay? The most common form is the skin version, the cutaneous version. You get these itchy, you know, little fluid-filled blister-like lesions, and then they develop the craters, and it has this black scab basically down in the bottom of the crater about 7 to 10 days after the lesions break out. You may get a fever, cough, and sore throat. So that they can, yeah, we're going to take antibiotics, going to take them for a long time, usually the end of that. Practice, contact precautions until you've been on the antibiotic, until your sores have healed over, that kind of thing, okay? But the respiratory version, like we had with these mailed-in letters, it can be a mortality rate of up to 90% in untreated cases. Because when you inhale it, it goes directly into your lungs, and so the spores actually get right into your cells immediately and can cause acute respiratory distress. You can ingest, you can accidentally ingest it, like and the people who used to get this were people who worked with livestock or worked with leather products because of the contaminated animal skins, okay? That's what we were familiar with traditionally about anthrax. So if I have it on my hands working with stuff, I could get it into my gastrointestinal system. Typically, it's not a big deal because often the gastric juices will kind of weaken it. But it can if it gets into the gut and gets and catches hold there, especially if those spores are implanted there, then it can cause sepsis. So all of them, the big thing is we treat them with long-term antibiotics. Doxycycline or ciprofloxacin, which is a fluoroquinolone, and they would take 60 days of medication. And it's really important that the patients understand, because this had spores in it, you need to take it long-term. And you'll find out that with C. diff, that's part of the problems with C. diff, even though it's not related to this. It also releases spores. Those spores get into the gut, and it is hard to knock it out. So standard and contact precautions, unless it's like I said, the bioterrorism thing. But the problem is that you don't know, they didn't know until they opened the letter that there was anything inside of it other than the letter. And I mentioned that it can be contracted with infected animals or animal products like leather. Anthrax, it's a bacteria, releases a spore produces a toxin. That's its claim to fame. Treatment, 60 days of antibiotics. All right, smallpox. The reason these pictures all look so old is because smallpox has been eradicated since the 1980s, so worldwide. So that you have to go into the history and literature of medical and some of the medical annals and old journals to find pictures of what it looks like. So smallpox, these blisters erupt on the skin, leaves these lesions. There's pus inside of these lesions. You can see this poor man is covered with it all over his face and trunk. This case over here, what is real interesting is this woman right here. See how she's got them? She's covered with them. This is her baby, her newborn baby, and the baby doesn't have them because the child was vaccinated. The mom had the lesions. They vaccinate the child, and he didn't catch it. Okay. So, smallpox. What's its deal? Smallpox is a virus. Was a virus. Other than biological stores in some of the different nations have basically like an infectious disease virology lab that's typically operated by government. There are some stored in some of the biological laboratories that different governments have, including ours, because if there were an outbreak, the best way to make the antidote for it or the treatment for it is to have a sample of it for a live virus to be able to make it from. All right, so it comes from the variola virus, and this one, well, it could be droplet, airborne, in contact, because touching the lesions can make you sick. If they coughed and they already had it, I mean, it lines your mucous membranes as well, then they could cough it out. And even could be airborne depending on the type of treatments that are necessary to help the patient. Even so, this one is contagious. The human's a natural host, and so it's really easy to transmit this from person to person. When you're exposed to it, you don't have any signs and symptoms, you're not contagious, then you get a high fever and body aches, and then after that you break out with these red spots and the tongue and the mouth, open sores, and then this rash all over the body. You're most infectious after the rash breaks out. Kind of sounds strange, but for smallpox, you're most infectious after the rash breaks out. And you're noticing that we could be, 2 weeks away or more from the original exposure before we have anything. And again, those pustules, like the young man had, those little pus-filled blisters, they then become craters and they scar. That was the thing about smallpox, is that it caused scars. Even the vaccination, and I didn't wear a short sleeve shirt, but I could show you that they were vaccinating still in the 1960s. We were still vaccinating for it. We quit vaccinating for it when the number of cases of it was less than the number of side effects from the vaccine, getting the vaccination. So the United States eradicated it in 1949, but we continued vaccinating up until I would think like the 1970s or so. So you don't have them, but if you find people probably over the age of like 50, they're probably going to have. I have one that's about the size of my thumbnail, and it's just like a little crater depression there. That I got that when I was young. It was pronounced eradicated in 1980 by the World Health Organization. The last known case was in Somalia in 1977. And so that's one of our big success stories with a vaccine with a virus. So how would we treat it if there were an outbreak today? The only treatment would be a vaccination, and it would be first responders, healthcare workers, people who are would become point of contact with people who are acutely ill and being treated, and they would vaccinate them. And that's how it's different. It's a virus. It's highly contagious. There's no antibiotic for the virus, and the treatment, quote unquote, is vaccination. Now then, these are FYI, hear me, these are only FYI, but the reason I list these is because we see West Nile locally, and the Zika virus, which was really more talked about, well, of course, since COVID, nothing's talked about but COVID, but the Zika virus is also still out there, and it can cause birth defects, so it's really important. Both of these can be transmitted through mosquitoes. We get those here, so that if you're running symptoms that look like these, you would want to be checked. The problem with the Zika virus, like I said, it's causing birth defects. Also, because these are viruses, especially are known to cause the Guillain-Barré syndrome. Now I don't know if you had it in musculoskeletal or if you're going to have it in CNS, but you are going to be taught about Guillain-Barré. It is a progressive paralysis. It starts at the periphery, at the feet, works its way up, and it can even involve the diaphragm, and that means you don't breathe, and then you end up on a respirator. It's self-limiting, so then it will work its way back out. It came up this way, and so this part got paralysis last, and so then that part will begin to restore function sooner before you get the function back in your extremities. Guillain-Barré. There were some early reports with people who had gotten the COVID vaccine as well. But and this is where the supposition is, it's the effect of viruses to begin with. That we see an increase of Guillain-Barré where people get these severe viral infections. Okay, and it's a neuromuscular disorder and a body's response to its immune system being activated by a virus. All right. I've seen one case of this in the last year, and it was a woman who had received the vaccination. She was 45 years old, had received her first COVID shot. 24 hours later, developed Guillain-Barré, and where I met her was on rehab because she was recovering from. It almost looks like somebody had a stroke, but it's really odd because hers was like more centrally located. So trouble with her swallow, trouble with blinking her eyes, trouble with using, getting making her hands work, fine motor skills. She had briefly been on a ventilator because it had worked its way up, and then as it worked its way off, it had left some residual paralysis and weakness, and she was now recovering from that. Again, the research that they're looking at, that it's no more increase in, at least the last time I checked on this, no more increase in the Guillain-Barré in people who've had the COVID vaccine than any other viral illness. It's what happens in some people as their immune response really overreacts to a viral insult. So if you start noticing somebody's got they're starting to lose their leg motion, and then it's, in a day or so they're already losing control of their arms or having breathing difficulty, they need to be gotten to a hospital. It could be Guillain-Barré. All right. But this is FYI, but you will get Guillain-Barré when I think it's under CNS. I think it's where it falls in the lecture. And it leads us to talk about disaster planning because our focus has really been more on this public health crisis, but we have to remember all of our hospitals, all of our first responders, they train all the time for disaster planning because as we learned August of 2019, that evil people will do evil things and shoot up a Walmart or whatever. And so we as healthcare workers, we need to know what is our role in a disaster. So you should become familiar with the hospital's policies. What does it sound? What do they call? What would be my role in this? And then understand that they have to work on the communications, make sure the communication is not disturbed or broken. That if it requires evacuation, like it's a fire, even in a hospital, we may have to evacuate a unit of a hospital. How do we go about that? How do we safely get patients who can't walk out of a hospital in a fire when the elevators don't work? So those are issues that hospitals have to deal with and address. Triage plans. The word triage means is from the French to sort, and in disaster, our prioritization changes. What we're talking about is, when we talk about prioritization, we're generally talking about dealing with the patient who's got who's the sickest first, whose needs intervention so that they don't deteriorate further. Triage in disaster planning is different because triage in disaster planning also has to label the component of, we have limited resources in staff, in facilities, in supplies, in transportation, transporting people from, say it's an explosion at a factory. And so the triage changes our prioritization. There we have to add the component of those who are the most critically ill that can be salvaged, that are beyond the point of they've bled too much and they are now they're about to die. Then those people would not take precedence if they've got blown, if their pupils are fixed and dilated, even if they're still breathing, they're going to be given supportive care in that disaster. And they're going to transport the person that had an artery cut and is bleeding, and we need to get them to a surgery and they can save a life. And that person is having a heart attack because of all the panic that ensued. Well, that we can salvage, we can fix, we can save. And so in a disaster, the sorting, the prioritization changes, because what the role is, this one right here, we need to do the most good for the greatest number of people in a disaster. And that's the hard part. If you read some of the stories about nurses that have been in war situations, that's one of the hardest things to do, is to do good for the greatest number of people when you have limited resources and capability and having to make those hard calls, okay? Triaging typically would involve a team with a physician, more than likely, if available, and a nurse, and they're going through there, and they're having to label people with tags to transport now. Can be transported by ambulance. This one needs to be medevaced out. This one needs to be given supportive care, and they have a place where those who are just going to be kept comfortable are watched over. Leave them just laying there, but they put them where somebody can monitor, be over them, watching them, helping them to have, to have as peaceful a passing as possible. And it's a much different. I hope none of you ever have to do this. My closest dealing with this was when I was working in Ethiopia, and we had just the rudimentary medical things. These were places that were distributing rations for people in a famine, but we started getting healthcare needs, and then we got people in that had fallen and knocked a hole in her head, and her skull skull bone is literally laying on her brain, and we got to get her out of there now, because if we can get that, we can fix it, save her life. Versus somebody that was brought to us that there's nothing we can do for them. We don't have, by the time we could get a helicopter up there and get them out, we couldn't save them. And I hope you never have to make those kinds of decisions. Fortunately, those were few and far between, but having to make those kind of decisions means you need to really have a home set of assessment skills. Now, in emergency nursing, they do triage, but the triage is different. The triage there is who is the sickest, goes back soonest. We get them right away. We get them to where they need help promptly. Those who are walking wounded can come in and sit down. They're going to be gotten to, but they're not going to, just because you walked in first, if you're walking wounded, you're not going to get to the front of the line in a triage at a hospital. Those people who roll in, that ambulance that rolls in and they're doing CPR, they're going to roll right past you, and that person's going to get priority. So in emergency nursing, that it's not this level of triaging, not the greatest good for the greatest number of people. It is prioritization, who needs help the soonest to prevent them dying. And so that's a different type of triage in nursing in an emergency room than, say, in a disaster situation. All righty. That covers my content.